Hello, my name is Allison Landis. I am going to be presenting my evidence-based practice presentation. Matching healthcare resources with patients' needs is a key factor to maintain safe care in ICUs. However, the optimal staffing ratios have yet to be completely established. There is a growing consensus supported by several high systemic reviews that there is a direct relationship between the number of staff available and improved patient outcomes in acute care. According to West and colleagues, ICUs were introduced in the 1950s with the idea that the lives of severely ill patients could be saved if they were treated in small, well-staffed units with access to the most advanced technology available. Because of this, ICUs require a much higher staff-to-patient ratio than your average medical or surgical units. The purpose of this presentation is to investigate whether there is a relationship between the number of staff, including nursing and advanced degrees such as NPs, PAs, and MDs, that are available in the ICU and the impact it has on patient survival. My research question is staffing ratios / high workload associated with increased patient mortality in acute care? Broken down into PICO: problem, patients in the acute care setting; indicator, inadequate staffing ratios and workload; comparison to adequate staffing ratios and workload. The outcome is the impact on patient mortality. For my article search, I used Google Scholar as my database. Initially, I searched staffing and patient outcomes. I found that there were a lot of journal articles published on this topic. I then refined my search to staffing and ICU mortality. I also then refined my search to more recent articles between the time frame of 2013 to 2018. I chose to review specific articles based off the research that was found within the study. Articles that specifically looked at ICU workload and staffing and its impact on ICU mortality. I also chose several observational studies that contained several authors with advanced degrees to help support the idea of reliability. I found an article that was specific to NP/PA staffing in ICUs and the impact it has on patient and mortality and outcomes. My reflection is I feel that the resources I gathered are from credible and reliable sources. They are also recent and relevant to my specific topic that I chose to compose my presentation on. Working in an ICU requires individuals to encounter many variables throughout a shift. Overall, the main priority and goal is to work as a team and improve patient outcomes. At times, this goal can be difficult to accomplish when staffing and workload is an issue. Many studies support the idea that a lower patient-to-nurse ratio is associated with a higher survival rate. Despite this data, thresholds have yet to be set. A patient's status in an ICU setting can change at the drop of a hat. This requires enough staff available to notice these subtle changes, such as a drop in blood pressure or a change in respirations. Additionally, patients in the ICU often have several comorbidities and often require life-saving procedures such as mechanical ventilation, vasopressive therapy, and renal replacement therapy, to name a few. A study by West and colleagues found that patients who were treated when workload was high were twice as likely to die as those admitted when workloads were quiet. There is a lack of appreciation among staff organizations admitting patients on the correlation that exists between the number of caregivers and the prognosis, according to Brunot and colleagues. Noted by many resources, an increased mortality is reported on off hours. This is often associated with reduced staff and higher workload. Brunot and colleagues found that most severe patients were admitted between the times of midnight to 07:59, the period the period when staffing is often found lowest. Notably, Nuraz and colleagues support this idea with their study that shows the ICU risk of death increased by a factor of 3.5 when the number of patients was above 2.5 for nurses, and by a factor of 2.0 when the number of patients is above 14 per physician. As stated earlier, these values were often highest at night. Next, I'm going to discuss the differences I found in my literature synthesis. With the rising demand for critical care and shortage in staffing, hospitals are searching for alternative ways to staff the ICU. One model involves the use of nurse practitioners and physician assistants. Conflicting studies share either a relationship or no relationship in patient outcomes between NP and PA staffing. As supported by West and colleagues, a higher number of consultants per bed is associated with a higher survival rate. Their study showed with the presence of consultants, mortality of a -3 changed to a 0.016. This presents as a death every 1,000 patients. Controversially enough, Costa and colleagues found that mortality was similar in ICUs with or without NP staffing. NP staffing or PA staffing is common in 72.4% of participating ICUs. These results didn't show an observable difference in mortality of patients. As compared also to other studies, which supported the time of patient admission and its impact on patient outcomes, West and colleagues' study showed that the time of admission with a covering intensivist did not influence mortality, rather than the patient's illness and severity and confounding variables had the most impact. Next, I'm going to discuss my reflection on my literature synthesis. What I gathered was the overall picture as improved staffing improves patient outcomes and decreases mortality. I did find that there was a difference in findings on the use of NPs and PAs. Although there may have been different results on the impact of patient mortality with the use of NPs and PAs, the use of them remains the same in the studies, that they are a supportive role in patient care management in the ICU. There was also a difference that I found in 2 of my studies between the correlation between nighttime admission versus daytime admission. Improvements that I feel that could have been made on my sources to improve credibility were that not all the studies were performed in the U.S. So this may have had an impact on the way that U.S. ICUs are run versus ICUs in France. Another study that was used was not a random representation. I feel that further evaluations and studies should be performed to support the use of U.S. ICUs. I am next going to discuss practice recommendations and my reflections on these. The first recommendation that I found was delaying admissions. As studies have supported, an increased workload is associated with increased mortality. A recommendation from Nuraz and colleagues suggested the use of delaying admissions during periods when times are experiencing a heavy workload with unbalanced patient-to-caregiver ratios. The next recommendation that I found was, should ICUs be staffed based on workload versus patients? Lee and colleagues suggested questions should be raised about whether ICUs should be staffed on the basis of actual workload rather than the number of patients, and conversely, whether bed capacity should be determined by actual nursing workload and staffing rather than physically empty beds. My last recommendation that I found was substituting nurses for doctors. West and colleagues recommended nurses and doctors in some clinical settings be substitutes for one another so that units that are short physicians may compensate by hiring more nurses. The reflection that I found on some of these recommendations I feel is difficult to achieve. Unfortunately, ICUs cannot deny patients due to low staffing and high workload. If there is an open bed, it will be getting filled. The second point on staffing based off workload versus patients, although this is a great recommendation, often seems difficult to achieve. Institutions will need to implement a workforce tool to measure the acuity of patients and based off these measurements, staff their units adequately, which would result in more costs to hiring more staff. Lastly, evidence supports the importance of teamwork amongst ICUs. Unfortunately, nurses have a limited scope of practice comparative to doctors. Therefore, I feel that doctors then would be overwhelmed being low staffed, and this would also have then a negative impact on patient care. The main points that I want you to take away from this presentation is that there is evidence-based research that proposes ratios of patients to nurses as well as patients to physicians. Insufficient staffing and high workload above the threshold increases the risk of patient mortality. Patient care is through a multidisciplinary approach to provide optimal care. Further research is required to look at the complexity of the current issue at hand to try and understand the interplay between staffing, patient factors, advanced practitioners, and work processes to provide the best clinical outcomes and decrease mortality in the ICU setting. These are the sources that I use. This is the end of my presentation. Thank you for watching.